Arthritis is going to be that spectrum of disease that in your teens and 20s and 30s you don't think you have any. You hit 40s, 50s, 60s, you get a little bit more. By the time we hit 70s, 80s, it gets worse. And it's usually a result of, as we talked, sports, trauma, and sort of a culmination of things as we get older. Arthritis is going to affect almost all of us at some point, to some degree, some joints. More common in an active population. These are the rates of hip and knee replacement, and then when you see the R, that means revising them. So you have a knee replacement, it lasts 10 to 20 years. What do you do if it fails? You have to get another one. So this gives you an idea of, it's pretty shocking on that curve. And those numbers are from 2 years ago. So total joints, the fastest group, of course, is going to be this age group. If you've made it past that age group, odds are with you now with the technology that you can have one joint replacement and it should last a long time. So let's talk about, specifically, let's talk about exercise. So we always say, people always ask us, when is it time to replace your knee? When you stop being active, when you have pain at night, when you're starting to sort of lose the health benefits of being able to exercise because of your knee, because of your shoulder, because of your hip. You'll start to see other joints affected. So obviously, all these are good benefits of exercise that can be limited if you have a really bad knee. So we want to keep everybody active. We want you golfing. It might cause mental stress, but shouldn't cause a lot of physical stress. So, these are just some of the benefits of exercise in general, and I think for all of us here, it's golf, right? We enjoy, a lot of this stuff improves when we can get out to the golf course, even if we are taking a lot of swings. So when you do have to go through a joint replacement, these are just some of the benefits. So improved quality of life, longer life expectancy, functional capacity, physical activity, all has been proven to increase. Very physiologic measurements improve. VO2 max, these are things we can measure. Workload and improved exercise tolerance. And this is pretty interesting. You take somebody that can barely walk before they get their joint replacement, and now they can do quite a bit more. So exercise improves afterwards. So I think what a lot of people probably here want to hear about is, if I have to have a joint replaced, or if I do, or my friend has it replaced, what do you tell patients? So we used to replace a joint and we tell you to just don't do anything. Just don't move. It might not work. Now, we encourage people to be active, but there are some limitations. The problem with all joint replacements are they're still cemented into the bone, and if that bone-cement interface is weakened, the joint replacement fails, and then you have a bigger problem. So you have to remember, high-impact exercise is never going to be good. Falling is never going to be good. So things like horseback riding, basketball, football, those are not so great with a joint replacement. Golf, tennis, pickleball, walking, hiking.
What about skiing?
So skiing, I tell my patients you can ski, you just can't fall.
Oh, yeah.
And if you fall, you can't fall hard. So you have to remember, what we put in you, cobalt chrome surgical steel, is much stronger than your bone. So what will fail is not the replacement. It'll be the bone itself or the interface. And the key is really the first 2 years. If you make it through the first 2 years of a joint replacement, the survivorship of that joint replacement goes up dramatically. So I put a total knee in somebody, I see them at 2 years, they say, "Doc, I'm doing great, the x-rays look great." Their odds of doing well now for 20 years are dramatically higher. If I put a joint replacement in you, you go golfing, you don't listen to me, 6 weeks after I put it in, you're like, "This is great." You're golfing and the thing gets loose, now we have a problem.
What's DHA, TKA?
So THA is total hip, TK is total knee, TSA is total shoulder. So different joints we can put in metal in. So the problem, and you're going to have a hip talk, so we'll save right? You guys are going to do some hips.
Yep.
So again, the number one problem with joint replacements is how they're fixed into the bone. The joint replacements themselves, generally with technology in the last 20 years, do pretty well. It's just, can we get them to stay in the bone? The younger the patient, the more demands, the higher the demands, the bigger the risk of that interface. So when you look at joint replacement failures, they're usually in very young patients that get it because they're too active, or very old patients because there's another medical problem or something else going on. So increased risk of total joints. There's the younger population. If you get a good joint in, you got to be good to it because it's hopefully it'll last you 20 years. High intensity exercise such as jogging with a knee replacement will cause them to fail earlier. Again, because of that interface. So that first 6 weeks after a knee replacement, first 3 months, when we're telling you don't go golf, don't go do crazy stuff, that's why. We got to get it to stick in that first 3 months and not get it loose. So all joint replacements have metal, generally metal and plastic in them. And as you can imagine, just like your tire, they wear, the plastic will wear. It generates microparticles. Your body sees those as foreign, and then that's what will cause it to get loose. So the more active we are with the joint replacement, the more wear it can get loose. We hope in the lab that won't happen for 30 to 60 years. We now have knee replacements on robot cycles that are going 50, 60 years without getting loose. But will that translate to humans? No one knows.
So were you saying that the inflammation would accelerate the loss of the implant that we said?
Well, what will happen is you'll get, so the process of loosening becomes, you get a knee replacement and you're really active with it and you get a little breakdown of the plastic. The more wear, microparticles of the plastic get into the joint lining and your body sees those as foreign. When those enzymes get released, they then can interact with the cement bone interface, and that's how it's used.
So the inflammation actually affects the interface.
Mm-hmm. And that's again a result of the foreign particles. So, if you catch that early, you pull the plastic out, wash all that debris out, pop it in the plastic, the joint replacement doesn't get loose, and you save the joint, in theory. So, again, let me just cut to the chase so we can talk all night about joint replacements, but I think the bottom line is, what do we recommend to people activity-wise? So, about 5 years ago, the American Academy of Orthopedic Surgeons basically said, Bill Mallon, who's a former pro golfer who actually I trained with him for a couple of years, great guy, and was on the PGA Tour for 3 years. He always says he was never very good, but he's really good. He looked up all the data on joint replacements in golf, and he's the guru. And if you ever, anybody gets hurt in golf, you'll hear that's who everybody goes to. And the bottom line is golfing, this is after a total hip, very successful. Usually you'll see an increase in driving distance with almost any joint replacement because flexibility generally improves for a while. And most people are using carts after hip and knee replacements. So you can see pretty successful and didn't really have a problem. Golfers, interestingly, hip replacements are going to do better than knee replacements with golf. Generally, even with knee replacements, people still had a little achiness, a little pain, a little swelling, but a lot better than they were before they had the joint replacement. Again, you generally saw some increased distance after you had a knee replacement, and people generally used carts, which is still probably a good idea. If somebody asked me if they have a knee replacement or a hip replacement, can they walk the golf course? Sure they can. Over the long haul, that is going to obviously put wear on the knee, so using a cart probably makes sense bottom line was, we know, from Chris's talk on meniscus, the downswing in golf puts a lot of strain on a normal knee. Of course it's going to do that to a knee replacement, and it's going to do that to the plastic. But the plastic we put in a knee replacement is super strong. So generally, the idea is still, after a knee replacement, turning the foot out, a little bit of a more controlled swing. These things are thought to probably reduce the wear on the lead leg if it is your lead leg. Don't have as much data. The trail leg generally sees about 1.5 times less force and torque. So probably you can take the advice on the lead leg and worry about it less on your back leg. So this is just a study. So if you do have to get your knee replaced, basically 57% of all knee replacements return to golf within 6 months. 81% golfed as much or more. Most reported minimal to no pain. Some still have pain. Most people enjoyed their rounds of golf more. So if you do have to get your knee replaced, it certainly isn't the end of the world, and it probably would bode well.